Self again? Sure. All right. Good morning. My name's Alina Gonzalez-Mayo. We're going to be going over psychiatry and hopefully ethics for Step 3. So let's begin. As you know, for the Step 3 course, it's basically conducted in a way that it's supposed to mimic, if you will, a grand rounds. So it's supposed to be a course that's very interactive. You're supposed to talk a lot and make comments to the professors when they're talking. Step 3, unlike Step 2 or Step 1, is not so much what the diagnosis is, because they're going to assume that you know what the diagnosis is. So what is important for Step 3 is that how do you treat these individuals? So what's the next thing that you do? So whether the patient goes into a hospital, do you treat the patient in the outpatient department, or do you use medications? And if you do use medications, what medications do we use? And that's what's essential in Step 3. So why don't we begin with psychiatry, where the chief complaint is, let's party. So let's look at the history. Police are called to a 34-year-old woman's apartment after her neighbors complained that she had been playing loud music all night for the past 10 days. Let's stop right there. What's significant about playing loud music for 10 days? Now, I'm assuming most of you, if not some of you, live in the city. What's that all about? Do you have neighbors? Are they loud neighbors? I remember my neighbors were very loud. The walls in the city tend to be very thin. So if you have, is this unusual? Loud music all night. What's unusual about it? If you have a loud neighbor, your neighbor's going to be loud every single day, from the moment you move in to probably the moment you move out, because you can't stand living there anymore. But what's important about this is that it doesn't occur all the time, but it occurs for the last 10 days. So this is not something that's continuous, that's pervasive. So we have something that's only occurring for a set amount of time, and that's going to be important. They discovered her pacing the floor in her brightly lit apartment at 2 a.m. That is also significant. Why? What are most people doing at 2 o'clock in the morning? Most people are sleeping at 2 o'clock in the morning, so it's not normal to find someone pacing up and down in a brightly lit apartment at 2 a.m. Any attempts to talk to her resulted in her becoming irritable and abusive. So now we see mood symptoms. So she's not sleeping, she's irritable, she's abusive. So far, you should be thinking of what this person has. She reportedly greeted them cheerfully and invited them in for a party. What does that show you right there? If I were to stop. The police come knocking at your door at 2 o'clock in the morning. Do you open the door? Well, you have to open the door. But do you invite them in for the party? What does that tell you about this patient? What is a word that I'm looking for? Judgment. This is a woman whose judgment is obviously impaired. She then attempted to engage the officers in a political discussion, saying that she had discovered the solution to the Middle East crisis and had just been trying to buy a plane ticket to Washington so she could explain it to the president. What could that be? Now, is it possible to have a solution for the Mideast crisis? People have been trying for years, but I'm sure someday, hopefully someday, someone will come with a solution. But if this were, let's say, Madeleine Albright, who is in her apartment. Remember Madeleine Albright? Who was she? The former Secretary of State. Okay. If this were her, it would be normal because that's her job. That's what she tries to do all the time. But if it's you or it's me, what could this be? What do we call this when people have thoughts that are not true? We call that a delusion. So she might be having delusions. What kind of delusion is she having? When you think that you have special powers, when you think you're very intelligent, when you think you've got the solutions to all of these things, what do we call that? That's called grandiosity. So this is a woman who's obviously displaying delusions of grandeur. When the police brought her to the emergency room, she was angry and resistant. Now, there's no history of trauma or significant medical illness. Physical exam is normal. However, her mood is labile and expansive. What is a labile mood? Labile means that it changes quickly. So if your mood is labile, you're angry one moment, you're sad the next, you're laughing the next. She speaks in a pressured manner. If I were to stop, when you think of pressured speech, what is it that you must think of for the test? Now, of course, you could see it in a lot of things, but you see pressured speech, the first thing you think of is mania. People with mania have pressured speech, and pressured speech, of course, is when you're talking a lot very quickly. Am I having pressured speech now? Am I talking too fast? No, this is okay? All right. Revealing that she has felt very little need to sleep over the past week or so, and that she had been fired from her job for inappropriate behavior. Now, we don't know what that is. And that she has been unable to purchase her plane ticket because her credit card has reached its limit. So this is a woman who's obviously spending a lot of money, buying a lot of things, and where do we see that as well? We also see that in patients who are manic. It's very common for patients with mania to spend all sorts of money, to buy not one car but 3 cars, to go into every single catalog that they get at their house and buy everything from the catalog. So then when their mania starts to subside, what do you think starts arriving at the house? All of a sudden they're bombarded with all these boxes of the things that they bought. And she's undisturbed by these events. So far, what is it that's going to help us make the diagnoses? Irritability, pressured speech, delusions of grandeur. How's her sleep? She's not sleeping. And how's her mood? Her mood is definitely up. So what would be the differential diagnoses at this point? For the purpose of psychiatry, it is essential that you always rule out anything that's medical. You're going to be in a lot of trouble if one day you have a patient who you're just thinking has a psychiatric diagnosis, and it turns out they have a medical diagnosis and you never did the workup. So before you or I say that something is psychiatric, we need to make sure that it is not medical or that it's due to drugs first. Because if it is medical or due to drugs, then of course we're going to have to treat it very differently. So what I want you to do is always think of medical diagnoses first, rule those out, and then we go and think of all the psychiatric disorders that these patients can have. So what could mimic this type of presentation? Could drugs mimic this type of presentation? What kind of drugs do you think you would have to ingest to look like this? Is it drugs that make you go up or drugs that make you go down? Chances are it's drugs that make you go up. What are the drugs that make you go up? The psychostimulants? We have cocaine, we have amphetamine. But is this the typical presentation of someone who used cocaine? Cocaine, if you remember, uses what kind of pathways? The dopamine pathways. So cocaine makes you look like what? Schizophrenic. Patients who use cocaine or amphetamines look like they're psychotic. They have delusions of persecution. They think that someone is out to get them. They think that they're going to be in trouble. They think that someone is bugging the house, that the house is wired for who knows what, that people are listening in on their conversation. But substance-induced is something that you have to figure out. What else could mimic this? How many of you drink coffee? When you drink a lot of coffee, what could happen to you? Could you get hyper? Could you be irritable? Could you not sleep? So could this be caffeineism as well? It's possible. Well, what's your big diagnoses here? This patient probably has bipolar disorder. What are other differentials? Cyclothymia, and we'll get to that. What is cyclothymia? Who remembers? Cyclothymia is basically a milder form of bipolar disorder, and we're going to get to all these differentials in a bit. And of course, the psychotic disorders. And here's the medical diagnoses, which would be hyperthyroidism. People with hyperthyroidism mimic mania, mimic bipolar. What does hypothyroidism mimic? Then it mimics depression, would be the other end of the spectrum. Now, if we think drugs are involved in this picture, when the patient is in the emergency room, what's the first thing you order to make sure that drugs are not involved in the picture? The first thing you order will always be the urine tox screen. Now, one thing that is very important, do we need consent from a patient to get a tox screen to check for drugs? How many of you just order it and don't talk to the patient about it? If any of you work in hospitals, how many of you do that? Are any of you residents? Are any of you going to speak? Usually it's very common. When I was a resident, I would order all kinds of things without even talking to the patient. And you need to remember, for the test, that is definitely a no-no. We always have to talk to the patient, tell the patient what it is that we're ordering, and tell them why that we're ordering. And why is that important? Because if this is a patient who, let's say, is using cocaine, and you tell them, ma'am, I'm going to test your urine because I think you've been using cocaine, what is she probably going to say? Are you going to say, sure, test my urine, find out how much cocaine I've been using? Chances are she's going to say no. So that is why we need consent to get urine tox screen. Does it happen every day in the hospitals? What's the answer? Do you think people get consent in the hospitals? No, of course not. But do you need consent for the test? You better. Exactly. So urine tox screen is going to be done, and we're also going to order a thyroid function test. Now, what do you think is going to come back from these tests? The urine tox, of course, is going to be negative, and the thyroid function, of course, is going to be normal. Let's talk about the urine tox for a second. Cocaine stays in the urine how long? Very little, short amount of days, maybe 2 days, maybe 3 days, that's it. What's the drug that stays in the urine the longest? Especially if you're a chronic user. Marijuana will stay in there approximately 30 days if you're a chronic user. So remember that when you go on interviews and they want to test your urine. Okay. Now, it's very hard many times to differentiate between schizophrenia and bipolar disorder. It might seem very simple on paper, but when you have a patient sitting in front of you, it's very hard to differentiate one from the other. And the reason for that is that schizophrenics can also have delusions. Bipolar patients have delusions. Schizophrenics are psychotic. Bipolar patients can also be psychotic. And because many times they are so similar, that is why, if you remember from step 2 or step 1, there's always a bias in the diagnoses. More whites tend to be diagnosed with bipolar disorder, whereas more African Americans tend to be diagnosed with schizophrenia. And that's only due to the bias of the physician. So if you have a white patient coming to see this physician who's white, the physician will probably say, you know what, you're bipolar. But if it's an African American patient with the exact same symptoms, assuming she is psychotic, then that patient will probably be diagnosed with schizophrenia. But basically, the main difference between mood disorders and psychotic disorders is what? That patients with psychotic disorders basically have an absence of mood symptoms. Okay? I'm going to be getting a pointer soon, so I don't know if you can see by my finger. So typically, let me repeat that, patients with bipolar disorders versus schizophrenia, patients with schizophrenia tend to have an absence of mood symptoms, where that's very common in patients with bipolar disorder. There's another type of disorder which is called bipolar II disorder, and many experts believe that maybe this is the most common of all the bipolar disorders. So bipolar disorder, what is bipolar, by the way? It's major depression and mania. So this is a person who fluctuates. This is a person who has mood symptoms that go up and go down. Bipolar II is someone who has major depression, so they go all the way down, but then their mania never reaches all the way up. So they have what's called hypomania. So what's the difference between hypomania and mania? It's not so much the symptom itself, but it's the severity of the symptom and how much the symptom affects your level of functioning. For example, how many of you have had days when you're talking a little bit more than usual? Nobody. How many of you have days when maybe your libido is a little bit higher than usual? You're like nudging whoever you sleep with and say, come on. Have you ever had days or nights like that? And you go to the mall and you were just going to go to buy one thing and you got home with like 3 bags or 4 bags? Have you ever had days like that? Only women have days like that, right? With the shopping and the 3 bags. Well, if you have days like that, then that's probably hypomania. That's the main difference between mania and hypomania. Mania is a patient who you know ends up in a hospital. Hypomania, not necessarily. So it's like I said, it's more the severity rather than the type of symptom itself. Okay. Let's get more information from the patient. In psych, as is true in any kind of specialty, we need to get as much information as possible. So if the family members come with the patient, what should we do? Talk to the family member. We need to know what that patient is like at home. Is that patient taking medication? Is that patient doing things that are putting himself or other people in danger? So what we do here is that we get as much information, if, again, available. What do we find? We find that the patient has never had any type of psychotic illness, with the exception of one previous manic episode 1 year ago, responded to lithium, and he had no previous depressive episodes. The moment you have mania, what's your diagnosis? It's called bipolar disorder. So we know that he had she had bipolar disorder in the past. She took lithium, she did well, and she's had no depressive episodes. Do you need depression to have a diagnosis of bipolar disorder? No. The moment you have mania, you've got it. Okay. This is where I'm going to skip a little bit. So before we go over the treatment plan, I want to go over the differentials. Okay. Let's talk about bipolar disorder. For you to have a diagnosis of bipolar, like I said, you have to have at least one manic episode. What is mania? Mania is the individual who has the elevated mood for at least 1 week. So their mood is up, they're euphoric, they're not sleeping, they're probably not eating. Why? Because there's so many other things to do. Why are they not sleeping? Because there's so many things to do at night. Their speech is probably going to be pressured. They're going to show poor judgment. They can't concentrate on one thing. Why? Because they're concentrating on many other things. What's common for bipolar is that it tends to occur when you're very young. Anywhere from 18 to 50 is the average age for the onset of bipolar disorder. The mean age is about 30. So it occurs when you're young, and a lot of times it occurs during the first few years of college. And how old are you in college? You're 18, you're 19, you're 20. That's why you see so many of these patients never graduate college. Why? Because they get sick and they never complete their college degree. So they're not sleeping, they're not eating. Flight of ideas. What's flight of ideas? Flight of ideas is when you're going from one topic to another very quickly, but there's always a connection between topic A to topic B. So anything will trigger another conversation. So if I'm talking to her about her green blouse, and I see he's got green shoes, I'm going to talk about his shoes because there's the theme connecting one thing with the other. And people with bipolar disorder tend to have that, and that's called flight of ideas. They're going to be involved in not one activity, but in a lot of activities. So if you see the college student, what would probably happen? He's involved in numerous organizations in school, in government, chess, sports, any other kind of organization. But how productive do you think these individuals are? They're not going to be productive at all. Why? Because they've got their hands in so many different pots that they're not doing anything that's very effective. And that's what you typically find in patients who have bipolar. You may have evidence of major depressive episode. What's major depression? Mania typically lasts, for you to make the diagnosis, like I said, it was at least 1 week. But do you need 1 week to have a diagnosis of mania? No. If you feel that patient needs hospitalization, even on day 2, then that's mania. You don't wait around and say, I'm sorry, ma'am, I can't do anything, because you're not officially manic yet. So you just hospitalize them, and it's immediately called mania. Major depression, on the other hand, is the individual who has the depressed mood and or anhedonia for more than 2 weeks. So basically everything is down. You're not sleeping, you're not eating, you feel helpless, you feel hopeless, you have no energy, you feel guilty, you feel worthless, and of course, what's the biggest risk for major depression? Thoughts about suicide. It's very common. Now, since this patient, well, let's talk about bipolar. How do you treat bipolar disorder? You treat it with the class of drugs called mood stabilizers. What are the mood stabilizers? We've got lithium, you've got valproic acid, and you've got carbamazepine. Those are considered first line. Those are the heavy hitters. Those are the ones that we use when anybody comes in with a diagnosis of these disorders. Unfortunately, what's the problem with these drugs? They do not work right away. It takes anywhere from 10 to 14 days to work for the lithium or the valproic acid or the carbamazepine. So what typically happens a lot of times on your test is that they'll give you someone who's got bipolar, meaning that they're manic, and they're in the emergency room, they're tearing up the emergency room, they're doing all kinds of things in the emergency room, and then they're going to ask you, how do you treat that individual? Do you give that individual lithium, or do you give them something else? And the answer, of course, will always be, you give them something else, because you cannot wait for lithium to work. Lithium, like I said, takes up to 2 weeks. So the other thing that is used in psychiatry is the standard. How do we treat agitation and aggression in psychiatry? We will either use an antipsychotic or a benzodiazepine. And those are our only two choices. Some experts will only use a benzo. Why? For example, lorazepam. And why will lorazepam be used? Which is Ativan, because it's very easy to give you lorazepam. If you're agitated and you're fighting me, all I have to do is get 3 big guys to hold you down, and then someone drop your pants, and I'm going to give you a shot. So you have no issue of saying, well, you know what, I don't want the medication. So lorazepam is used very frequently. If we talk about antipsychotics, what do you think is the antipsychotic that's used a lot in emergency situations? It's haloperidol, not because haloperidol is better than Risperdal or risperidone, or because it's better than olanzapine or quetiapine or anything like that. But what's the difference between the atypicals versus the typical as far as the presentation of the medication? The only one that comes in an IM preparation, unfortunately, are the older ones. So if I have a patient who's agitated but is willing to take medication, they've actually done research where they go up to a patient and show them a needle and show them a pill. So, okay, mister, whatever, now I know you're upset and I'm going to give you medication. What do you prefer? Well, what do you think most people would prefer? I mean, most people would prefer the pill rather than the shot. But if that's not possible, then the only thing you have left is to give the individual the haloperidol. So in the emergency situation, benzos or antipsychotics are the drug of choice. Okay. Let's talk about substance-induced mood disorders. So what was it that I was talking about earlier? I was talking about cocaine, which is the big one, or I was talking about caffeine. Let's talk about cocaine. Individuals with cocaine, for example, cocaine use. When you stop using cocaine or when you use it, you will develop different kinds of symptoms. When you use cocaine, what typically happens? You become agitated, you become psychotic. When you withdraw cocaine from the system, what happens? You become depressed. So when you think of someone who is in cocaine withdrawal, for example, what's the biggest risk that these patients have? What you worry about is suicide because they have depression. So what's a substance-induced mood disorder? You could have depressed mood, for example, in cocaine withdrawal. You could have diminished interest or pleasure, for example, the cocaine withdrawal. But if it's, let's say, psychostimulants or even caffeineism, what are you going to have? You're going to have the elevated mood, you're going to have the expansive or an irritable mood. So these are the two poles that we're looking at in substance-induced mood disorders. You're either going to be up or you're going to be down. There's going to be no evidence from the physical exam that the symptoms developed within a month or drug used. And basically, let's look at the third one. It's only used when the symptoms are severe enough to merit independent clinical attention, so that you have a patient who it is obvious in the question. Now, please, it has to be in the question. If not, don't think about it. Don't think of something that's not even mentioned. If the question that we were discussing right now, the woman with the irritability, the abusive behavior, the not sleeping, the wanting to buy, the plane ticket to Washington, if it's in the question that she has been using certain substances or that she recently went to the doctor and the doctor put her on new medication, and since she was on medication, this is what happens, then this is what you think of. If that's not there, you don't think about it, and we move on. How did we rule this out, first of all? What did we do when we admitted this patient or when she was in the emergency room? We did a urine tox. The urine tox came back negative, so we forget about this. It's not, if the urine tox is negative, we don't think about this ever again, and we move on to different differentials. Now, cyclothymia is basically a mild form of bipolar disorder. Let's talk about dysthymia. What's the difference between dysthymia and cyclothymia? Dysthymia is a depressed mood. Have you ever had days where you feel blah? Anybody here? Did you wake up today and say, oh, I don't really want to do anything today. I'd rather stay in bed. I'd rather go shopping or whatever. I don't want to do anything, but you sort of get up and you get dressed and you come here and you're sitting here saying, oh, why am I here? I should have done something else. But you basically go on with your life. If you have a lot of days like that for more than 2 years, then that's probably dysthymia, which is a mild form of what? Major depression. So cyclothymia is a milder form of what? Bipolar disorder. So your depression or depressed mood is never severe enough, and your mania is never severe enough. So you have what's called the depressed mood and a lot of these hypomanic episodes. Why would we not think of cyclothymia in her? What was essential in the history? How long has this been going on? 10 days. How long does cyclothymia have to occur before you give them that diagnosis? 2 years. At least 2 years. So because that's not there, if the 2-year period is not there, do not think of cyclothymia. And you treat cyclothymia, by the way, the same way that you would treat bipolar disorder. You could give them mood stabilizers, the lithiums, the carbamazepines, etc. Now let's talk about schizophrenia. Why does this patient not have schizophrenia, but it's still going to be a differential because they can be so similar? How long has she been having these problems? 10 days. For you to have schizophrenia, what is essential in the diagnosis? You're going to have for 6 months. So at least for 6 months, what is it that you will be seeing? But at least for a 1 month period, you're going to have 2 of the following. Delusions. Delusions are false beliefs. Did she have false beliefs? Yes, but the difference here is that typically schizophrenics have what kind of delusions? Bizarre delusions. People with mania or with delusional disorder, for example, have what kind of delusions? They can be believable. Is it possible to come up with a solution to the Mideast crisis? I mean, we hope it's possible, so that's not bizarre. You also have hallucinations. What was a hallucination? False perception. Did she have hallucinations? There was no hallucinations in the thing. Disorganized speech, disorganized behavior, and negative symptoms. And this is going to go on for at least 6 months. It tends to affect your level of functioning, so you probably end up getting fired. It affects your home life. It affects everything about you. It's not due to drugs, and the way to treat it, of course, is with antipsychotic medications. But why does she not have schizophrenia? She doesn't have these psychotic symptoms, and the symptoms have not been present for more than 6 months. So what did we do with this? We ruled it out as well. So let's go back and think of what her final diagnosis would be. What does she have? Bipolar disorder. What kind of bipolar disorder? 1 or 2? Does she have mania or hypomania? She definitely has mania, so we call it bipolar disorder. So let's treat her. Oops. What would we do with her? Who would treat this woman as an outpatient? When you're in the emergency room, there's only 2 ways to go. Either I release you and make a referral to outpatient if I think it's necessary, or I admit you into the hospital. For this woman who's gone on the shopping spree, who's trying to buy a plane ticket to Washington, who's doing who knows what with the cops, who's playing loud music, who's not sleeping, who's obviously getting in trouble at work. I believe she was fired. What would you do with her? Would you say, well, thank you for coming to the emergency room, but I think you can go home now, or would you admit this patient? Who would admit her? Who would let her go? I think most of us would admit her, so we're going to admit her. Let's add a little ethics to this case. How do I admit someone into a hospital? Now remember, what is essential for you to be admitted into a psychiatric hospital? The first thing we have to do to this patient is offer hospitalization, assuming that she's able to give informed consent. For the purpose of the test, what do we assume about every single patient? And I'm going to use the word competence, even though it's a legal term. Understand that I'm using it so that you understand, but it's not a medical term. The judge is the only one that can declare you competent or incompetent. For the purpose of the examination, every single patient is what? Every single patient is competent, unless it's clearly stated in the question itself that this patient definitely does not have the capacity to make a rational decision. For example, the patient says, I don't want treatment because my spaceship is outside and it's going to take me to Pluto to get treatment there. Is that a person who you should say can make a decision on her own? Definitely not. But if they mention a schizophrenic, what do you assume? That they're competent. If they mention an alcoholic, what do you assume? That they're competent. If they mention someone with dementia, with Alzheimer's disease, what do you assume? That they're competent. For you to change that answer, they need to tell you something else. The Alzheimer patient who doesn't know what day it is, who doesn't know what his name is, who doesn't recognize his family, who recently burned down his house, who doesn't even know where he is, who thinks half of his body is missing. Is that an individual who is competent? Definitely not. But if they just use the word Alzheimer's, then you have to say they're competent. Same thing applies for mental retardation, etc. So, patient comes in. What do? You sit down with her and you say, ma'am, I believe you have bipolar disorder, and I think you need treatment. And what do you think the patient will say? Treatment? Ha! I don't need any treatment. There's nothing wrong with me. Who are you calling me mentally ill? I want to be released right now, and I'm going to walk out of this emergency room. What do we do then? Do we let her go because she has the right to refuse? No. When we're dealing with psychiatric patients, the way that I can admit you into a hospital is with the following criteria. Number one, you must be mentally ill or developmentally disabled. Those are the two big ones. Does she meet that criteria? Is she mentally ill? Yes. Then let's look at the second step. You need to assess one of three things. Number one, she's a danger to herself. Number two, she's a danger to others. Or number three, she's gravely disabled. And by gravely disabled, they mean that you're so sick that you really can't take care of yourself. Does she meet any of the criteria that I have mentioned? What do you think? Yes, which one? Danger to? Danger to herself. She's doing things that could put herself in danger. So, does she meet the first part? Is she mentally ill? Yes. Is she a danger to herself? Yes. So can I admit her involuntarily? Yes. So let's assume that's what we do. We admit her involuntarily because what did she tell us? She said, no way am I going to be admitted. There's nothing wrong with me. If anybody here needs treatment, it's you because I think you're the one with the problem. So we admit her into the hospital. What's the next step? What do we offer her? What do we offer people who are into the hospital? Do you want to give her medication? Yes? What medication do you want to give her? If you want to treat her as acute mania, what would we choose? We could give her an antipsychotic or a benzodiazepine. Trust me, they will never give you an antipsychotic as a benzo as a choice. Because if they do, you know what that means? That question is out of there. Because psychiatrists are probably split half and half with that treatment plan. So we give her an antipsychotic or a benzodiazepine, calm her down. But must she accept treatment? We admitted her involuntarily. Does she have the right to refuse? What do you think? This is America. I admit you involuntarily, you still have the right to refuse treatment. So if she refuses treatment, can I be sneaky and put the haloperidol in her soup or in her cereal, or walk by with a syringe and all of a sudden, oh, Did I bump into you and give her the medication? Can I do that to this patient? What do you think? Definitely not. What typically happens in most states, if not all states, is that the only way I can treat you is once, and that is if you are in what's called imminent danger. If you're, let's say, very depressed, and you're not eating, and you're sleeping, and you're thinking about suicide, and you don't want admission, I admit you involuntarily. Why? Because you're mentally ill, and you're a danger to yourself. But if you're just sitting there on the ward, not talking to people, not doing anything, can I treat you? If you say no, the answer is no. So the only way I can treat you once is imminent danger, so that if you start fighting on the ward, I could give you a shot once. If you do something on the ward that puts you or other people in danger, then I can treat you against your will. But does that mean that I can keep on treating you? No. What you have to do next is then you have to go to court. If the patient's refusing treatment, you go to court and prove to the judge that this patient needs medication. Without medication, they're not going to improve. And what do you think happens most of the time? Most of the time, the judge says, yeah, whatever, and you start giving these patients medication. So remember that patients still have the right to refuse, even if they were admitted involuntarily. But let's take another scenario. We admit her. She says, yes, I want admission because I know that I'm not doing well. I've spent all my money. I took money out of my 401k, and that was what I was going to retire with. I'm wiped out. I can't believe I've done that. So, yes, I want to go to the hospital. We admit her. What else do we do then? We still offer medications. What medications do we talk about with her? We're going to talk about the mood stabilizers. What are they? Lithium, valproic acid, and carbamazepine. And before she can give us an informed consent, what's essential that we discuss with her? What is informed consent? Let's begin with that. What has to be discussed for informed consent? This is ethics now. What has to be discussed for informed consent to be granted? Number one, what are the risks? So we have to tell the patient what are the risks, for example, of the medication. What else do we have to tell the patient? What are the benefits of the treatment? What's the good thing about the medication? What else do we have to tell the patient? What's the purpose of the treatment? Why is it that we're providing such treatment? What else do we discuss? If there's other things available, availability of other alternatives, or other alternatives, I should say. If you refuse this, then there's this that is also available for you. If the patient says yes to everything, then what do? We start with the medication. But she is interested in treatment, and she says to you, okay, but I want you to tell me what are the side effects of lithium, and what are the side effects of valproic acid, and what are the side effects of carbamazepine, and what are you going to tell her? Let's start with lithium. What do we know about lithium? Good drug, but it has what's called a narrow margin of safety. You always have to check levels. What are the common side effects of lithium? GI distress. Patients complain of diarrhea all the time. What else happens? Anorexia. What else happens? Tremors is very common. So you get a lot of tremors in patients who are on lithium. What else happens? Hypothyroidism. So anybody that you want to start lithium therapy on, what's one test that you will have to order? You order TSH. Lithium is also teratogenic. It causes cardiac malformations in the fetus. What do we call that? Epstein's anomaly. So if you have a woman of childbearing age, what's another test you have to order before you start lithium therapy? You have to do a pregnancy test. What else does lithium do? Lithium is nephrotoxic. It affects the kidneys. So what do you want to make sure that you do? You want to make sure that you check kidney function. Lithium can also cause conduction defects. So what could be another thing that you do before you start someone on lithium therapy? You might want to do an EKG. So I've mentioned the 4 essential things that you do before lithium therapy. But if the exam gives you a female, what is the test? A 30-year-old female, not an 80-year-old female. What's the test that you would want to order? And they tell you can only order one. You better order a pregnancy test, exactly. And once you start patients on lithium, it's essential for you to tell them you cannot get pregnant on the medication. If you want to get pregnant, you need to discuss this with me. You need to discuss it with your OBGYN, and we can come up with a plan so that you do not get pregnant. And if you do get pregnant, you need to tell me, because I have to stop the medication right away, especially during what month? Or at least the first trimester, because that's when organogenesis occurs. So what are some other side effects of lithium? I've already talked about the common ones, the tremors, the diarrhea, the thirst, hypothyroidism, the pregnancy one. It also causes acne. It also causes a lot of weight gain, so that's something that patients, you need to discuss with them as well. It also causes leukocytosis, which tends to be rather benign. And it also causes diabetes insipidus. Now, what happens when your lithium level goes up? What will you see in these patients? What you'll find is ataxia, so they'll have a gait disturbance. They can also have seizures, and they could also go into coma. So it's very common, especially if we're talking about toxic doses. And if a patient is in lithium toxicity, let's say levels above 2 or 2.5, what is the treatment of choice at that point? Dialysis. Dialysis is how you get rid of the medication very quickly. So she says, well, lithium, I've been on lithium in the past, so I understand lithium. So why don't you tell me about this other drug, valproic acid, that I've never been on? Well, what do we tell her? It's also a good drug, but what happens? It affects the liver. So what do we have to check? We have to check liver function. What else happens with valproic acid? It's also teratogenic, so we have to make sure that she's not pregnant. And remember, LFTs is something that we have to check. What about carbamazepine? Also hepatotoxic, so we check LFTs. Also causes rashes, and here's a big one, agranulocytosis. So what combination is never done? Carbamazepine with clozapine, because that's a lethal combination. But because this woman was on lithium, what would be your drug of choice for her? This is a good little bit of information. If the patient responded to lithium in the past, the symptoms went away, what's going to be your first choice? If they give you lithium, valproic acid, and carbamazepine as choices as next step in the management, what would you use as your next step? You're going to use whatever it was that worked before. Why? Because you know that it's working. Why use a new drug that you don't know if it might not work at all? So you put her on lithium. What if you have a family history, let's say, that the drug worked on the mother? She's never been on medication, for example. I'm changing the scenario. She's never been on medication, and she tells you, my mother has valproic acid. My mother has bipolar disorder, and she's been on valproic acid. Then what could be first line for you at that time? Then it becomes valproic acid. Why? Because a lot of the research indicates that if something worked on a family member, chances are that it could work on your patient as well because of the genetics. So if something worked on someone else in the family, try that first. And that's a good rule of thumb. So we're going to hospitalize her, and we're going to give her lithium. When do we decide to release her from the hospital? How long do you want to keep her? Luckily for psychiatry, we don't have, the utilization review people, the DRG people, they're not so much on our case as they are in other people's cases. Why? Because psychiatry is so vague. It's also subjective. I could tell you, well, the patient just isn't right yet. What's our favorite word? The patient's not at baseline yet, whatever that means. So it's much more gray. So they really will not have this time frame that they have to kick the patient out. But private facilities, trust me, have a time frame, because Medicare only pays for a certain amount of days, and forget about Medicaid and payment. So for her, we try to treat her as quickly as possible, and when we decide to discharge a patient, we always go back to the reason of admission. Are the symptoms better than when she was admitted? If a patient comes in suicidal, wanting to kill themselves, what's the first thing we make sure that we write on our note and we assess before we decide to let the patient go home? Whether or not they're suicidal. Because you ask them, are you suicidal? Oh yeah, when I go home and you release me, I'm going to kill myself. We definitely do not let go of that patient. So we need to talk to that patient at what point? When we're thinking, the moment she gets admitted, we start to process and we start to get who involved. We try to get as many people involved as possible. And what department do we rely on in the hospital to help us with all of these things? So for psychiatry, who do we always call? Social services. We always call the social worker. And what will the social worker do for this patient? We need to make sure that she has follow-up. We need to make sure that maybe we bring in the family to get family sessions going. Why are family sessions needed for psychiatric patients? Why do you think? Do you think the family is affected as well? The family is very affected. This is a woman who's probably living at home. I don't know if she lives at home, but think of the average patient. They live at home. There's chaos at home. The patient is very disruptive. So the family unit is very disruptive. So we need therapy for everybody. The patient needs to realize how their behavior not only affects them, but how it affects everyone around them. So we contact social services, and when we're thinking of letting her go, we need to make sure, what is it that we're going to ask her, this particular patient? Tell me what you think about the Mideast crisis. And she's going to laugh. She says, oh, I can't believe I did that. I can't believe that I thought that I was being so silly, doctor. Of course I was sick. What if you walk in the room and she's on the phone and says, wait, doctor, I'm on the phone to US Air, seeing if there's any space on the shuttle that leaves at 8. What does that tell you? You better keep her. Don't let her go. Because if this woman were to leave, now think of all the security that's around Washington today. If this woman were to leave, what do you think she might do? She might actually go up to the White House, if she could, and knock on the door. And what do you think is going to happen? These 10 big men with like machine guns are going to come up to her and take her away. So that is not what you want your patient to be doing. So we need to assess, how is her thinking related to the Mideast crisis, her wanting to buy a plane ticket, her trying to visit the president. And if she says, I can't believe I did that, there's nothing, then you can let that patient go.